My name is Nicole Bernier. I'm the research director at the IRPP. Thank you. I am the research director at the Institute for Research on Public Policy. The research program I'm involved with is the Faces of Aging program. And I am pleased to introduce Dr. Nina Chappell, who is a keynote speaker, and she will speak on home care issues for Canada. Dr. Chappell is a social gerontologist, and she is working in the Sociology Department at the University of Victoria. And her themes of research are informal and formal care for older adults, quality of life in old age, aging among Chinese communities in Canada, Hong Kong, and China, and healthcare policy. Dr. Chappell has also, as you know, like the IRPP is working with university researchers to bring studies for public debate. And Dr. Chappell, you have one of her studies, the study that she published with the Institute for Research on Public Policy. It is in your delegates kit. So today, the title of her presentation is Home Care for an Aging Society, Why It's Needed and How It Can Be Effective. Please welcome Dr. Chappell.
So what I would like to talk about today is, of course, home care. I'm going to take a little bit of a different angle because I knew that Marcus was speaking, and Marcus and I do a lot of work together, and our passion lies squarely in the same spot. We've been longtime advocates of universal national home care system for older adults, and Nicole reminded me at the break that we met apparently right after the Romano report was released, and there were a series of workshops put on by CHSRF to talk with provinces about areas that they felt had been neglected in the Romano report. One of those was home care, and I was asked to speak as a home care researcher, and she said to me, your point then was they've neglected home care. And I'm saying the same thing today. So I'm not sure how much new I'm going to have to say, and I can't touch that. And I'm a little bit concerned that I'm speaking to the converted. Anyway, here goes. So what I'm going to do is I'm going to go in, take an angle through informal family caregivers in order to get at home care, because I thought it would be a bit different from the panel that you heard first thing this morning, all of which were great presentations. Okay, we moved the computer, and now how do I make it work? I pressed the arrow, and there, I pressed the wrong arrow. Okay, so what I'm going to do is I'm going to talk just very briefly about older adults and some of their needs. Because we argue, and I'll try not to make noise, but I have to move this. We argue that one of the things with the healthcare system is that it should be starting with needs and not with services and eligibility for services. That if you want to make sure you're servicing needs, start with the needs, not with what services happen to exist. And so I want to start with what are the needs of older adults, and then I want to go to caregiving, informal caregiving, which is the dominant care system in our society, and one which gets mightily neglected when we talk about health care. I'm going to then talk a little bit about caregiving in the future when us baby boomers, I'm one, get there, and we seem to have scared the living daylights out of out of the system, and then talk about, of course, the need to support caregivers, and then the role of home care in supporting both older adults and caregivers. So older adults, and I'm sure most, if not all of you here know this, they suffer primarily from chronic conditions, not acute conditions, and our healthcare system has been designed to treat acute conditions. That is what medicine has been designed to do. We don't have a cure for chronic conditions. That's why we call them chronic. Chronic conditions get worse the older we become in old age. So Dawn is absolutely right. We all grow old, we all get sick, and we all die. But we don't all do it at the same pace, and we certainly don't all do it in degrees of severity until we reach very old age and until, in fact, we're close to death. And one of the issues, and it has prompted some of the things I'm going to talk about today, is that when we talk about the Great Gray Tsunami and we talk about older adults bankrupting the healthcare system, we lump them all together. And we make the generalization that we're all going to be as sick as the sickest older adult we know. And that's just not reality. Functioning also declines as we age, but it is not, it doesn't work in synergy with our chronic conditions, fortunately. So many of us suffer from chronic conditions, but we don't necessarily suffer from functional disability. So in other words, many of us function, and actually many of us function very well with our chronic conditions. I have Meniere's disease. I have had Meniere's disease since my late 30s. It's a bloody pain, thank you very much. I don't appreciate having it. But I function very well. You can't tell that I have any chronic illness. My physician has said to me for years, I don't know whether to call you the sickest of my well patients or the wellest of my sick patients. You know, but the point is, in old age, as we contract chronic conditions, we often learn how to function quite well and to maintain our independence while we are nevertheless experiencing chronic conditions. Although our functioning also declines as we age. Bad news. The good news is that if you look at overall well-being, also known as happiness, life satisfaction, subjective well-being, it's in fact no worse in old age than when we're young adults or middle-aged adults. In fact, there are some studies that suggest we are more satisfied, more content, and happier, which young university students that we teach have a hard time grasping because they look at the outward signs of old age, right? They look at our drying skin and our graying hair or our graying hair under our dye, and they, you know, and they say, but you must be miserable. The research in that area absolutely flies in the face of that. Now, why that is, I can't tell you. I don't know. There's a lot of speculation. We compare ourselves when we're older with our friends who are worse off. They're the ones who've already passed away. We always know people who are in more pain or more suffering. Many things that were important to us when we were young, we've been there, done that. Thank you very much. They're not a concern. They aren't as important. We don't really know. What we do know is that all of those studies tell us that certainly material things become much less important. Family and friends become number one as we age within old age. We also know that while it's absolutely true, some people don't have families and good social support around them. National Statistics Canada surveys, these are people living in the community, not in congregate living, not in nursing homes, or they're a bit skewed, but it's still an impressive figure. The 98% have family and friends that they feel close to. So we are not all lonely, we are not all isolated. And despite geographic mobility, particularly of the younger generation, over 85% of older adults live close to at least one child. And figures in the United States show that that number is about the same, and has increased by 2 or 3% over the last couple of decades, despite what we say about our mobile society. We also know that most older adults can live in the community with social support, and that is where they prefer to live. And Dawn is absolutely right. We want to live in our own homes. We do not want to end up in institutions. And why should we? Those of us who are younger don't want to live in an institution, so why should we change when we are older? The mainstay, when we do need help and our health does deteriorate, is the family. Family forms are changing. We know now that the nuclear family that us baby boomers grew up with, of parents and young children, is no longer the majority of family forms in Canada. We've got single parent families, we've got gay and lesbian families, we have blended families, we have all sorts of family types. We also know that while the forms of families have been changing, their function has not. People, human beings, our species, we gather together in small groups. We share, we support one another. It is our preferred way of living. And when one of us or more of us need help, we help one another. And that has not changed in modern day society, despite what we hear about how selfish us baby boomers are, and we're very selfish, how materialistic we are, how individualistic we are, how geographically mobile we are, but we look after one another. And those of us who are baby boomers today are, in fact, the caregivers to those who are older adults today. They are our parents. And we haven't run away. We haven't said we don't want to care for you. We are there. And we know from a lot of research in caregiving that it's not all motivated by love. Some of it is. But it is motivated by reciprocal bonds and ties, whatever they're called. And most of the caregivers to older adults we know are women. We've been hearing this for a long time. They're wives and daughters. And the reason I have the figure up there is because it isn't as overwhelmingly women as us gerontologists have suggested all of these years. We are right that the majority of care comes from women, but it is 56.5%. It's the majority. Well, 43.5%, that's a big chunk of men who are stepping up and providing care as well. And what we do know is that when there isn't a woman available, the wife perhaps has died first, which is more unusual. There isn't a daughter, or the daughter isn't geographically close and the son is. We know that men step up and provide that care, although we tend not to acknowledge them as much. We know that between 70% and 90%, it depends on whose research you read, of care to older adults comes from family and friends, primarily from family. And we know that for just under 40% and for women and over 40% for men, in old age, they receive only formal care, no care from the formal healthcare system. Okay. So I'm going to sort of not spend much time on describing this. We know a lot about care that is provided and that comes from the informal network. Let me say something very quickly about caregiver stress, because there's so much literature there about caregiving stress, and I understand it, and I understand where it comes from, and is used a lot to say caregivers are so stressed, we have to help them, you know? And near as I can tell, it's not making too much effect. We're still not helping get support for caregivers. I would rather take a realistic approach to it. Let's see what the data say. And when it comes to caregivers, I think we'll be much more successful if we argue from the facts, which are that family caregivers are not looking to get out of caregiving. They're not saying, I don't want to do it. I'll present some studies later on. They're not saying, give them formal support so I can run away and play. And furthermore, it is only a proportion of older adults at any one time who really require assistance from the formal healthcare system. And it seems to me that in presenting it that way, it's less scary, you know, to the people who control the purses, because it's not this big deluge that's going to come out of the woodwork and say, help me, help me, help me, I need all of these services. The vast majority of older adults don't want formal care, thank you very much. They aren't very impressed with how they're delivered and what they have to go through to get them. So they actually try to avoid them. So if we can present it in a much more realistic way, we get away from this tsunami concept. Similarly, with caregivers, yes, it's stressful, but it's not continuously stressful. The studies show that high stress tends to come and doesn't always stay forever. And for the people it does, they're the people we have to help, okay? At the same time, caregivers say, but yes, it is burdensome and it is stressful. So the idea here is to try to present a realistic picture rather than taking it to the extremes. And we know the caregivers who are in fact most stressed and need help, and they tend to be people in our society who are more disadvantaged. They have fewer economic resources. They're the ones who are in fact socially isolated and don't have any assistance themselves, and so on and so forth. But it is only a portion. And I'm going to skip, I think I'm going to skip that slide too. There is much to do about the informal and the formal interface. So we know the vast majority of care comes from family and friends. We know the healthcare system is worried that if we provide more support, that they're going to go bankrupt. So there's actually now a lot of research in different countries that looks at the interface. So the question is, we know most of the care comes from families. If we start providing more assistance to help those families, then what's going to happen to the family care? And the concern that government officials will tell you, not in public, is that, well, if we start, and someone who spoke this morning said this, you know, it's not, I think it was Marcus, it's not a matter that, well, we're just going to give everyone a free cleaning lady, which is what some of the government officials say to me. Well, I'd take a free cleaning lady too if someone gave them to me. That's not what we're talking about here, but that's the mentality often. So there are two ways in which we would argue we want to provide formal support for older adults and for caregivers. The more we can assist older adults with home care and continuing care, and I'll get more into that in a minute, the more we help the caregivers, right? Because they don't have to do it. If we provide some formal assistance to the caregivers, we also help both them and the older adults, because then we take a burden off the caregiver. They can do it longer. They can sustain the support that they're providing. And I'll talk a bit about that later on. But I want to tell you, first of all, about a particular study by Janssen that was done in Europe, although there are now a few of these studies that basically show the same thing. I like this particular study, which was conducted in 11 different countries in Europe. And what they did was to compare Southern European countries have what we call more familialistic care systems. It's actually a nice name. It sounds to me like, well, I should like that type of system because they support families, right? But what it really means is the state, the government, doesn't provide much by way of support of anything to help families. And by not providing child care or services for older adults or services for anyone who really becomes sick or disabled, everything is left to the family. That's what the family system means. So government doesn't do anything, so family does everything. But I wish they'd changed their name because I like their name. And then sort of middle Europe, France and Germany and so on, they're sort of mixed. They've got some services for childcare and for older adults and so on, but not a lot, but some. And then when you go up to sort of Northern Europe and the Scandinavian countries, they're sort of known for providing many more services at both ends for children and for older adults. And I'm going to talk more about Denmark and Finland in a minute. So the question that Janssen had was, so what is the difference in family support when you've got these different levels of support from government, okay? And what Janssen finds is, first of all, when you go to the citizens and ask them what they think government should provide, everyone in every country believes that government should provide services for older adults in need and should help out families care for those older adults in need. And in those countries where governments provide the least, they feel it the most strongly. They're adamant, and in fact, they're angry that the government isn't providing the services. In the Scandinavian countries, where a lot of services are provided, the citizens sort of take it for granted, but when they're reminded of it and asked their opinions on it, they absolutely support it. And what happens when governments provide services? Families continue to provide care. There is no evidence that families stop providing care because governments provide services. What does happen is that older adults receive more care because they're getting care from both sources, and family members have some of the burden shifted because some of the tasks that they help with shift. And they also have more time for providing emotional support. And this is only one example. There are several studies. In fact, Marcus and I are now taking this topic and we're completing a book, which is, I got a big smile for Marcus on that. We've been slaving away on this book and we can see the end of it. And there are at least a dozen studies or more that show the same thing that we cite. But there's also a big issue about the future, about, remember us selfish baby boomers. We're the ones who are going to enter old age. And there have been a few studies by Carrier and Keefe and Gamu and other colleagues who have taken projections, because we know that us baby boomers have fewer children than our parents. We know that sort of what our marital transitions look like for baby boomers. We know how many baby boomers there are. And what they find is that there are going to be a greater proportion of baby boomers in old age who live longer into marriage. okay? And we know that the spouse is the first resort to care. So the thinking is, well, if you live longer into old age as a couple, then you'll have that social support lasting longer. We also know that the proportion surviving into old age with surviving children will be an increased proportion. The reason, by the way, there are going to be more couples is because women's life expectancy is increasing, but men's is increasing faster, so there's a narrowing of the gap. But our children's generation is the first one where we don't know if they're going to live longer than their parents in a long time. I'm looking at Andrew because he's a demographer, and he knows these figures better than I do. So there's potentially good news there because couples help one another and children look after us in old age, right? So there could be some greater support for baby boomers in the future. But the sort of bad news on that is that when you look at the actual numbers, because there's many more of us baby boomers, right? So even though the proportion of us in old age that are widowed or divorced is smaller, the actual numbers not in a couple that are going to be alone is higher. And if you are alone, you're more likely to turn to the formal care system. And the numbers without a child are also going to be higher, even though the proportion is larger. The numbers without children, and it is spouses and children who are the mainstay of informal care right now, okay? So if you take the baby boom generation and project, it's good news and bad news. And we have all sorts of unknowns. And someone touched on this this morning. You know that we don't know what type of group living is going to evolve amongst us baby boomers. I mean, some of us, particularly in gerontology, are already talking to our friends about our living arrangements as we get older to help one another, and we aren't too confident the men are going to be around to help us. So we're making our own plans. And we don't know how prevalent new arrangements are going to be. We don't know with older couples, even though there's going to be a greater proportion in couples, the extent to which they're going to be able to look after one another. Because with everyone living to old age now, we're living to old age with complex health problems. So we're going to have more older couples. Both individuals are going to have complex health problems. How much are they just going to be able to look after one another? And even though we've got greater proportion of couples, it's because the men aren't dying off as quickly. We do know about these men who can provide the care when we need it. Are you listening? That they're more likely to bring in formal services, and they're more likely to put us in nursing homes. So if that's all they're going to do to us when we get there, I'm going with my girlfriends and we're going into some sort of group living arrangement to look after one another. But they're unknowns, right? I mean, we don't know what's going to happen here. Someone mentioned this morning, of course, us baby boomers, we have fewer children, but we have siblings. And currently, we know that some siblings certainly step in, but they're not the dominant form of care. But maybe the baby boom generation will change that. We don't know. We also don't know the extent to which our children are going to provide the care that we're providing. There's a new study out of Quebec by Guberman where she's arguing, I don't know if I like the term, but she's arguing for a denaturalization of caregiving from children. She's finding that children now providing care in Quebec to older adults, they certainly want to be there for their parents, they want to provide care, but they have limits, and they're very aware of those limits. They're going to put on those limits, and they expect the government to come in with services. They don't expect to do everything. If this is a trend for our children, it's going to change things significantly. So there's a lot of talk now about baby boomers. Most of you probably saw the recent issue of the Gerontologist came out. It's all on the baby boom generation. And we just don't know. Oh, all right, there's more stuff. I want to then move into the formal care system, continuing care, and home care. And I want to talk about it in terms of supporting families and supporting old adults. We know that the care that comes from family and friends constitutes about 70% of all care that seniors receive. So we're talking dollar figures now, despite all of the hue and cry about the impending bankruptcy of the healthcare system. So the argument is, and Marcus and I give the same argument, and that was why I decided to focus on caregivers, is that we know what we have to do, we know what we should do in order to provide better quality of care in old age, to provide the types of appropriate services that older adults need, and there is a way that we can do it that it will be cost effective. And that is what I want to move into. A large part of that, though, is to also support families in a way that we are not supporting families now. And by supporting families, I do not mean the Harper government came out a few months ago and said that, well, one of our solutions is we are going to promote cohesion. No, yes, it was cohesion. Cohesion amongst families. Well, that's just code for saying families have to do more of the caregiving, right? I mean, families are cohesive now, thank you very much. To say we've got to promote cohesion suggests that families aren't cohesive now and families aren't doing enough. We have no evidence that families can actually do more than what they're doing now. I mean, in the aggregate, I'm sure the odd family could, and some families are also doing so much that they're burning themselves out. But when you look at the whole picture, there is nothing to suggest that we can ask families to take on more than what they're doing. Okay, so let's look at home care, and I'm going to repeat a very little bit of what Mark has said, but mainly I'm not going to. All of healthcare right now in Canada is 88% publicly funded, dropping down a little bit, but it's now at about 88%. Home care, a whopping 2 to 4% of those public healthcare dollars go to home care. That's about the same as your percent going to palliative care within home care, isn't it? We did see at the very beginning of this century, or just before the beginning of the century, there was a lot of talk about increases to home care, and it drove me nuts because so little money was going into home care. You know, a percent, you could give it 10% increase, it wouldn't amount to very much money. But governments at the end of the 1990s were all waving a flag about these increases to the home care budget. Shortly after that, they started decreasing monies to the home care budget, and then it leveled out. But so you've got minus 3.4%, minus 0.7%, but almost 20% increase at that time in private expenditures going into home care. So people know they need home care, but families are paying for it for older adults. And it's not just older adults themselves, it's us children who are often paying to help the parents as well. So it just supports what was said earlier. Home care does not have a priority. And a lot of the home care money has been going with so-called health reform and following Romano and Kirby and Health Accord into short-term home care. It's going into intensive post-hospital care. Someone, I think it was Donna, noted earlier how surgeries are now, the vast majority are now on an outpatient basis. That's fine. We don't have any evidence that that's bad for the patient. But what it means is it shifts home care dollars to post-acute care. Older adults primarily need long-term chronic care. And so what is happening with the home care budget that is there is it's being funneled out to the short-term intensive care. And no one argues that these people shouldn't have this care. They should have it. But it's taking away the long-term chronic care that was being built up in the 70s and 80s throughout this country. And you could find evidence for it in CIHI figures and some others, which I'm going to skip over. But to emphasize what Marcus was saying earlier, that we now have Canadian research which supports the preventive function of home care and home support services. So said another way, that if we provide some of these non-professional support services, that we can actually affect significant cost savings to the healthcare system down the road in terms of emergency hospital use, in terms of admissions to nursing homes, and those sorts of things. We also have made in Canada research that shows that it is possible to look after most, not all, most of older adults at home at the same level of need as in a nursing home, which the vast, vast majority of them prefer. That is what they choose. And I think you had this slide in and you took it out on me. So, and I had taken it out because you had it in. This research shows that caring for someone with the same level of need at home with home care compared to looking after the same person with the same level of need in a nursing home costs 40 to 70% of the cost of looking after them in a nursing home. The cost increases as the level of need increases. The only time looking after them at home cost more than in a nursing home was when they were dying. Why? Because when we keep someone at home at the present time, we don't have proper hospice care. We don't even have call-in lines to call to help family members. This is a family member. They don't know this is it. So they rush them to the hospital because they know there's some sort of health crisis going on. And that is what is spiking the costs up. So absolutely we need more attention to palliative care. And if we're going to build palliative care at home, we have to be careful that we don't turn the home into an institution so the person can die at home. So the point of this research is to demonstrate that providing home care can be cost effective. But a key point in all of this is that it isn't necessarily cost effective. So if we take our system right now, the way we have it today, and we expand home care and we provide more services to older adults and we provide more services for family caregivers, and I want to talk about that in a minute, it might be a cost add-on. It might not be, but it could well be a cost add-on, because in some senses, you know, the more services you provide out there, the more people you can find to provide services to. But there is a mechanism, there is a way in which you can do this, and you can affect cost efficiencies within the system. And you do that by having an integrated care system. So, you know, you need the standard stuff like a single point of entry and a single assessment and all of those things. But key to it is you have to be able to make those low-cost substitutions for the higher cost care. If you don't make those cost substitutions, then there's no guarantee you in fact are going to have a cost-effective system. So the idea is an older adult comes, first and foremost they have their needs assessed by an assessor who knows everything within the system. You figure out what the needs are, and then you say, well, how can you put the services together? And there's always different ways you can put services together, and discuss with the client and the family which way they would prefer and which combinations are most cost effective. And at least 9 out of 10 times, someone was referring something this morning, 9.999 probably out of 10 times, they're going to choose staying in their own home. Thank you, Don, you set it up very nicely. And in fact, if you have an integrated system, you can also start bringing in the third sector, the non-health sector, which is totally left out of this whole discussion and shouldn't be. There are all sorts of not-for-profits, charities, neighborhood groups. We talk about building community. How the hell do we ever build community when the first thing we do is we shut out that level when they enter the healthcare system? When a dear friend of mine, an older adult, was in a terrible car crash, they wouldn't let me in the hospital to see her because I'm not family. You know, her husband and her daughter, who treats her worse than a stranger, were allowed in to see her. She kept asking for me. She said, I'll sign whatever paper you want. I want to see Nina. I wasn't allowed in until her health was at a certain level, and then I was allowed in at non-family. They're shutting out support. They're shutting out community. How do we bring community back into this? All right. So no one is suggesting we replace caregivers. No one is saying caregivers want to be replaced. In fact, in every country in the world, families help each other. That's what makes a family. We wouldn't call it a family otherwise. So there are a variety of ways that we can help families. We don't do much at the present time. At the federal level, there's a couple of things like the Federal Family Caregiver Tax Credit. It's a credit, not a benefit. So you have to afford the money and then ask to be credited. So people who can't afford it to start with, it doesn't help them at all. At the provincial level, there are 3 types of respite. I'm sure you all know this: sitter attendant, adult daycare, short stay beds, typically underfunded. Many provinces, they'll say, well, if you want your mother in adult daycare, make sure you come at the beginning of the fiscal year, because halfway through the fiscal year, we got no budget left, and you'll have to wait until the beginning of the fiscal year. Manitoba just declared, I was just there last week, they declared Caregiver Recognition Day, which is great. But there are a lot of real-world examples in other countries that are doing much more for caregivers than what we do. And what they are doing are in all sorts of reports from the Canadian Caregiver Coalition and from other groups that say this is what we should do, but we don't do it. And I'm just going to, I don't have time to go through Finland and Australia, but just to look at Denmark very quickly. They give home help free of charge to seniors, eligibility determined by need. There is, income is not taken into account. Informal caregivers are entitled to lost earning when caring for a dying relative. There has to be a medical assessment that hospital treatment is futile. Seniors and their family decide where care is to come from. It can come from local authority, it can come from a for-profit service provider, or it can come from a family or friend. But it's entirely up to the older adult and their family, and the local health authority pays if the private option is chosen. Finland has some other things, but much better than ours. 2 days a month isn't much off for a caregiver. They have an allowance for caregivers, but 2 days a month off is better than nothing, right? And they arrange for care in those 2 days. And while the informal caregiver is providing the bulk of the care, the local authority insures them against injury and pays pension benefits. I don't have time for this. Australia, many of you here will know Australia. One example of what they do, Those unable to work due to caregiving can apply for, this is means-tested caregiver payment equivalent to the retirement pension. So the point is, there's lots of things that other countries are doing that help caregivers, and those countries haven't gone bankrupt. We also know, and I'm not going to go through the details of this, but I did with a graduate student recently for the Public Health Agency of Canada, a review of literature on interventions to assist caregivers. We know how to help caregivers. We know what caregivers need. When it comes to the policy arena, Janice Keefe has grouped policies for helping caregivers into 3 areas in terms of home care policies, workplace policies, and income security policies. And Marcus and I have done some similar writing, broadened it to include things like age-friendly communities and combating ageism and so on, but also assessing caregivers. But have also looked at integrating care for caregivers into an expanded, integrated home care system, which Marcus prefers to call continuing care system, so nothing is left out, and care is provided to both older adults and the caregivers. And here, to repeat, Marcus couldn't hold it in response to the question, to recognize and revalidate integrated continuing care systems at all levels of government, to adjust provincial and national data collection and reporting so we can even track expenditures in continuing care, which has become impossible with the fragmentation, to ensure health accords and so on, agreements, focus on integrated care, not only home care, and I'm going to talk about that in a minute in my closing remarks, and to foster, improve, and adapt integrated continuing care systems. So what it all comes down to is fixing the healthcare system for an aging society. Since the first of the baby boomers turned 65 last year, there is a much greater attention to issues that have to do with an aging society. Us baby boomers scared them if we did nothing else. And so you do see increasing calls for expanding home care, community care. Australia has just adopted a policy. What's interesting about this policy is that they've explicitly adopted an expansion of home care as a cost-effective measure. That's why they're doing it, okay? There's a recent report from the Health Council of Canada, and a couple more have just come out, on caregivers and supporting caregivers. So we're getting lots of recognition. My concern is who pays. That came up at the end of the panel discussion this morning. And what I am really concerned about is that we can put together the argument. We can put together the argument from lots of great research now around the world, including Canada. We can put together the logic of it in terms of the functional needs, needing to maximize quality of life and independence, that these are truly health problems, but they don't all require medical care. We've got the data, we've got the logic, we've got the argument, okay? What I'm worried is happening is that governments are going to embrace exactly what we've said, and they're going to turn it all over to the private sector. That's my concern, especially with this government in Ottawa today. So if they turn it all over to the private sector, which I'm sure sees a great market to make money in, we will have not won this battle. Rather, the likely consequences will be, and I believe we can see signs of them now, retrenchment back to a medical-focused healthcare system, which is where we began. This ongoing spiral in medical costs will continue, so the older adult doesn't get the home support that they need, so they fall down and break a hip in their own home, and then they have to go to medical emergency, and then they're admitted in for medical care. That's your medical cost spiral, right? The main services, the long-term community care that's required by older adults will be subject to affordability. In other words, if you can pay for it, you'll get it, and otherwise you won't. The opportunity to not only build an appropriate system, a healthcare system for older adults in an aging society, but the opportunity to affect cost efficiencies will be lost. We're going to pay our doctors, we're going to pay for more drugs to fool around with our brain. Ask me back to lecture on that. And that'll be it. There will be a less optimal quality of life in old age, and there will be greater demands on family caregivers, which is all very depressing. So in conclusion, it's possible to have both an appropriate and cost-effective healthcare system for an aging society, and it requires an expanded home community care system that supports both older adults and their family caregivers within an integrated system of care, but it requires both political will and grassroots action. Thank you very much. And I'll take questions. So I was talking to the converted, right?
You mentioned at the beginning, you referred to Roy Romano's
Yes.
Healthcare Commission. Yeah. And if I am correct, he did suggest a national home care policy. I don't see anything like that happening anywhere in Canada. And also the important point you just made about privatization of a lot of services means that there are two contrasting streams. But when you say it requires political will and grassroots action, and your question earlier was around how one builds power in the community base, that's my question. How does one build power with these strong trends which are sort of anti the establishment of a national home care policy?
Yeah, well, to address Romano first, he recommended a national home care program, but the whole focus in his report was all short-term home care, remember? It was, why you'd recommend 2 weeks help for someone with mental health suggests you don't understand mental health illness, right? But, pardon me. But anyway, it didn't. Where it went, actually, was it was out of those Romano recommendations on the short-term help for home care, and then there was Kirby and there was Health Court and so on. But they, in fact, did follow those short-term recommendations and put money into, and they tied the provinces to, it was all short-term home care. And that's part of what's allowed hospitals to shift to outpatient surgery, right, is that shift to home care to go to the short term. But they have to take the money from the long-term chronic needs of older adults. And I answered that in desperate hopes that I would come up with a brilliant answer to your second question, is how do you do it? I don't. If I knew how to do it, let me tell you, I'd be up here telling you how to do it. I don't know how to do it. I do agree with Marcus, but only to an extent, that our role, my role, I'm an academic researcher. But I've sort of never been one to let it lie there. And I would be out in the streets doing whatever. It wouldn't bother me in a bit. In fact, I'd love to do it. But I haven't figured out how to make that effective either. And whatever effect I have, I think at this point, for me personally, comes from whatever academic credibility I'll have. So I do, like a bunch of others, I make presentations to Senate committees and I do all of that, hoping to have an effect. I don't think, though, that is to say that we should for a minute stop doing the rigorous research, because what it does provide is a background for when the time is right. So if you look back to the early 90s when reform was taking place, and people in Canada looked around, there was a lot of talk about home care at that time, but there wasn't much Canadian research. The research that I was talking about that shows the cost effectiveness, we did that in the late 90s. In the early 90s, there wasn't. So they turned to the United States, where there had been a lot of research, and they turned to our friend that I say, gritting my teeth, Weissert, and he adamantly counseled them that home care would be nothing but a cost add-on, and it was absolutely the wrong road to go down. Well, if we had had the type of Canadian research that we have now, I think we could have effectively countered him, because it was a time where they were open to it, and we didn't have the Canadian data. So I think we do have to build the knowledge base. And I'm a social scientist, so we always say in the social sciences, well, eventually we'll take over the world, because the university students always take the social sciences and they end up in the government jobs and they end up in, Of course, I'm not going to live long enough to see it. But I also think that there is something to understanding, like when I said the comment this morning, I sat down and I thought, okay, I know my line of research when I'm retired. We now have to understand better how to shift these powers that be. And it does have to do with these vested interests. I mean, I am convinced of that. My whole program of research now has to do with drugs for elderly people, so I'm really hot on these pharmaceutical companies, and not in a good way, I tell you. And something's got to happen here. I mean, we really got to do something. So there's something about what, and I don't know what to do, but until we really can affect the people who have the power, we're not going to affect any change here. Sorry, I'm not being very helpful.
I would like to add something. Can you hear me? I'd like to add something. We at the Institute for Research on Public Policy, we are a think tank, and this is what we're doing. We are getting the ideas that are being built in academic research, the data, the evidence that has been provided by researchers such as Nina Chappell, and we're taking this to decision makers, to the public forums. And I can tell you, for having produced Nina Chappell's study in the fall, we got a lot of media coverage. It kept going for days and days, which told us that the public is ready for these issues. The public is really hungry to hear what researchers have to say. But researchers tend to publish in academic journals, so this is why it's difficult for the data to get to the public, to the media, to the decision makers. And this is what we're doing, and we're pursuing this work further. So,
There is the pressure towards privatization and pulling back on the government providing care. What I'm seeing in the work that I do with community planning tables is pressure to increase the volunteerization of services, beyond Meals on Wheels, volunteer drivers, volunteer non-medical home support. I'm seeing it as a tip, and I wonder if you're seeing anything in that too.
Yeah, so a long time ago I actually did some work with Volunteer Canada and was sort of very interested in the issue, but I'm not that up on it anymore, except it seems to me that there are two sides here. I think we have to be very careful that we don't exploit. And it's sort of the same with everything. You know, government is always eager to find cost savings by shifting costs. So if you take a societal viewpoint, it may be saving the government money, but it's costing someone else money, right? So it's shifting costs. It actually isn't saving costs. But to do it in a way, if it ends up exploiting, is not good. On the other hand, I would love to see a mechanism where we figure out how to build community, where the healthcare system is not so isolated. I mean, we talk about silos within the healthcare system, but the healthcare system is a silo itself. And instead of, maybe it shouldn't be done through the healthcare system. Maybe we need a separate coordinator outside of the healthcare system that can link not only the healthcare system, but NGOs and community groups and so on, who often want to help us and want to assist. It's a sense of community that we typically strive for. And so we want to build that, but we want to do it in a way in which we don't exploit. And it's a very difficult, it's really sort of walking a line. And I'm sure there are others that know better how to do that than I do. It's not really my area. But I know the downside, I know the upside, and I'd like us to figure out how we can do that. So I don't want to disparage volunteering. I remember when I did a state-of-the-art paper, this is a number of years ago now, on volunteering, and I was struck that the research at that time, at least, on volunteering, it was all about organizational volunteering. So basically, you defined yourself as a volunteer for an organization, and that's how you were a volunteer. And I was having discussions with these people in Ottawa, and I said, well, wait a minute. I mean, you know, I got an elderly neighbor, and I swore a lot, but I did shovel the snow, because it does occasionally snow in Victoria, and I live at the top of a mountain. I shoveled his snow for him, you know. Well, that's volunteering, so there are a lot of issues in volunteering that haven't been resolved. And in family caregivers are volunteers. I mean, we interact with one another. And when we talk about building community, in a sense, what we want to do is we want to build that very natural interaction of living together. And so we don't want to formalize it too much and bureaucratize it into a role that. So I have lots of empathy. I have no answers. Anything else? You've been very patient.
We could all understand how important home care is, but I would like to focus more on the expression integration or an integrated system. Okay. And it seems you do need organization and you do need structure. Yeah. And one of the things that bothers me a lot about the research, it doesn't go down to the grassroots. There's no way of speaking to the grassroots. That's particularly what I'm most interested in. There are many, many seniors, they never hear any of this. They don't know what you're talking about. And I think unless there's a thrust somewhere in working with grassroots seniors all across the province about what are their needs, how do they perceive the system, and why isn't it working, you'll get a lot of answers. I think there's something wrong in where our emphasis and our thrust is. As far as integration, the problem is the agency that should be providing the integration, like, say, regional health authorities, are not doing it. If you start putting it into other areas, then again, you have a fragmented system. You don't have an integrated system. I really don't know what the answer is to that. Okay.
Well, I think there's two questions or two comments there, two issues. and one is getting knowledge to the grassroots. And I would like to say a couple of words about that. I absolutely agree that we don't do it as well as we should, and we should do it more. I would also, though, point out that over the past several years, the funding agencies for academic research have been making it mandatory that we do much more of this. So much so that academics are feeling that they're so into knowledge translation that they don't have time to do their research anymore. Sometimes when you've got both sides complaining, maybe you've found the middle, you know, and in fact, it's becoming very standard now that we not only publish in our academic journals, but we publish in many other outlets as well. And in fact, some of the research that I've been talking about this morning has been written up in Seniors 101 in Victoria, for example. I've given talks to all sorts of seniors group. But just as important as, and that's not to say we can't do it better, but just as important as that I think isn't not well understood, that for many, many of us, we do our research, and I'm sure Don and Donna, that just twigged, and Marcus as well, and I know I do it. Our research is, in fact, the voice of seniors. When it comes out of our mouths, it may sound more like gobbledygook, but in fact, the ideas come from seniors. Most of the research is going out and actually talking to seniors through all sorts of means now. And many of us, in fact, go back to those seniors, not all of them if the sample is too big and whatnot, and some of them don't want us to come back again, but to many of them to say, this is what I am hearing, what you are saying. Can you tell me if I've got it all wrong? I've done this since the 1970s. I have older adults on advisory committees to my research projects from the very beginning, for them to help me understand what it is I need to understand. And they're with me throughout, and at the end when I start interpreting what I've heard from everyone, to say, does this sound wacky to me? And they are invaluable because they're a headache. They make my analysis last at least 3 times as long, because every time I meet with them, they say, yeah, but you haven't thought about this, and what about this? And then I have to check that out. But that's not well understood when we get up to talk, because they only give us an hour and a half to talk. And the talk isn't focused on, all of sort of what you did at that level. So that's a bit in defense of how we do it. I think we do and try, but again, it's not to say we can't do it better. And your second issue was an integrated healthcare system, and how do we do that? And Marcus and I try to give a number of recommendations in terms of what we think has to happen. So I'm not sure if you're asking for something more specific, or what are you asking for there? Well, I mean, you're right. The cultures are different, and that's part of the problem, right? And some people are going to feel they're losing while others are gaining. So, which is why I think, and I don't think we put enough attention on it, we have to start looking at Where are the power centers? Who perceives they're going to lose in this? And if we start looking at it that way, maybe we can, in addition to the arguments we've come up with, maybe we can start finding arguments so those people don't feel they are going to be the losers. They can start looking at things differently. But part of it is understanding a recognized division of labor, but where everyone is valued for the role they play in it. And that's not entirely the case right now. And did you want to say something about it, Marcus? No? Oh, he doesn't. I was hoping he'd rescue me. Okay. Yeah, it is. It's political. And, I mean, we know with powerful groups like physicians, if you want to get them to change, you have to go to the informal leaders within their communities, right? And, I mean, it just seems like such a daunting job. But so identifying the groups and then identifying, and there's a whole bunch of different players in this. It's not just one, right? But we have to start getting a different approach in here, as well as what we're doing. I think what we're doing is valuable, but I think we're missing a big piece there. Okay. You've been very patient. Thank you.